Welcome back to Between Two White Coats, a podcast designed to help you be the healthiest version of yourself. I'm Dr. Michelle Plaster, a family medicine doctor.
And I'm her co-host, Amber Foster, a family nurse practitioner. In our combined 30 years in medicine, we've seen a lot.
We're discussing key issues surrounding health and wellness, answering some of our biggest questions, overcoming health obstacles, and giving patient-centered advice in hopes of educating you and providing the tools you need to live a healthy life.
If you find our podcast helpful, please consider subscribing so you don't miss an episode. And don't forget to leave us a 5-star rating and review. This will help other people find our podcast.
Thanks for joining us. We look forward to serving you. Welcome back to Between Two White Coats, and we have with us today our friend Dr. Marcus Sims. Dr. Sims is a cardiologist who we share tons of patients with. I can't even count the number of people that I have referred to you over the years. We have you on speed dial.
Poor Dr. Sims. I'm so sorry. Please look at this EKG.
How many EKGs have we touched you?
Thank you so much.
Yes. Sometimes when we step out of the room with an EKG, we're like, I'm not so sure.
I'm worried about this patient. I feel like Dr. Sims needs a
and then we come back in confidently. It is because you then talk to us about the EKG.
You told me what to do.
Yes. And we're like, okay, we need to send you to our friend. So in our last episode, we talked a lot about preventing heart attacks, preventing cardiovascular disease. We talked about cholesterol levels that matter, what is a cardiac calcium score, and different screening and preventive things we can do to try to stay on top of, to the point where we never have the day where we have chest pain or move forward into a heart attack. But not everyone does that. Right. And sometimes even when we're trying to do that, we can't avoid all things. So let's talk about chest pain first, because I think we all get those patients where they're like, well, I've been having chest pain off and on for about 3 months. Right. Or I'm in to talk to you about my diabetes.
Or I'm short of breath. I've got a lot of patients that are like,
yes,
hey, I'm short of breath, and they think it's like lung issues. And I'm like, this sounds like your heart.
Yeah. So first, what are the symptoms that someone should not be ignoring because it may end up becoming heart disease or a heart attack?
Sure. So, like you said, chest pain that's kind of unrelenting. People who have shortness of breath, people who have syncope or passing out episodes that, aren't normal. And sometimes people have palpitations, that would kind of concern you. And then we have our diabetics who don't have typical angina or chest pain or shortness of breath.
Which this is
fatigue.
Many fatigue. That's a big one. Many years ago, though, it's probably one of the first times that I had even, like, Shelley had you come in and talk to us about heart failure, like a lunch and learn with the providers. Mm-hmm. And you said something, and it's been 10 years ago probably, and it has stuck in my brain, is that if patients are diabetics, they pretty much just need to be seeing you. Right. Like, the risk is so high for diabetics. Yeah. So any of my diabetic patients, I'm like, you need to go get a stress test. You need a cardiologist, because it's not if, it's when.
Right.
People with diabetes tend to go, oh, I don't want to lose my leg one day. I don't want to end up having kidney issues. But the number one cause of death for diabetics is heart attacks. Correct. Is cardiovascular disease.
Yeah.
And so in the mix of trying to prevent all the things, the most important thing we can do for a diabetic is prevent a heart attack.
Right.
And the risk of having a heart attack for a diabetic is the same as a person who has had a heart attack before.
Correct. They call that basically diabetics as having coronary equivalents. So if you're a diabetic, act like you already had a heart attack. And kind of go from there.
And if you already had a heart attack, you would have a cardiologist.
Right.
And so I do think for diabetics who are trying to be proactive and live long and prevent heart disease, that for diabetics to have a cardiologist makes sense. We have some patients who, I have high blood pressure, I have a cardiologist. Like, great. If you have a good relationship with a cardiologist, that's great. Let's have smart people help us prevent bad things.
For sure.
And you're right, diabetics, they have neuropathies, they have other very atypical presentations. So also with a diabetic, they're not going to get that elephant sitting on the chest. I have impending doom. I'm confident I'm having a heart attack right now. That may not happen.
Right.
So they're going to sit at home and kind of miss some of the potential warning signs.
Right. And having an event and not know it or not be here.
Yeah.
And so, just like we want people to know their cholesterol numbers and know their blood pressure, you should know what your hemoglobin A1C is, and if it's 14, that's not okay. Right?
Yeah.
Because that's double what our normal sugar is before we had diabetes. So Ideally you want to get it down to less than 7, 6.5-ish.
Yeah, because it's that elevated sugar that is really doing damage to your blood vessels.
Yeah, and accelerating atherosclerosis or blockage in your blood vessels.
Yeah.
So a lot of times, say if you were diabetic and you hadn't seen a cardiologist, and we get a stress test on you, and it's either grossly abnormal or there's this TID ratio, which is transient ischemic dilation, which means you have multi-vessel disease. And then we get in there and then you have 3-vessel disease and need to have bypass surgery, because the guidelines say if you're diabetic with 2 to 3 vessel disease with normal heart function on echo, then you should have bypass surgery, not stents. And then you go into this whole fight, just like we do about statins, on, well, why can't you put a stent in this vessel and this vessel and this vessel? So they want you to do, 3-vessel bypass via stents, which we do on certain people, but not everybody. So,
and this whole idea of getting to Dr. Sims and cardiologist and learning that you have multi-vessel disease, or that you have one vessel with a partial blockage or full blockages, I think it's easier for people to understand if we say, well, you start to get a buildup. You start to have vessel disease due to elevated sugars, due to elevated cholesterols, and first you have partial blockages, and blood still gets through there, so you don't end up with heart damage. And then as time moves on, you start getting 80% blockage, 90% blockage, 100% blockage. Well, then no blood gets through there. Depending on how big the vessel is, you start getting significant levels of heart damage. And enough heart damage, and you could have a sudden cardiac death. Small amounts, you have these small heart attacks where then your heart's not going to be as strong as a pump as it used to be.
Right.
But when you get to them before they get those full blockages, and you go, oh, you had an 80% blockage, but you were still getting some blood through there, and maybe not enough when you exercised. So when you exercise, you start feeling some discomfort, chest pain, increased shortness of breath. You start telling yourself, I think I'm just out of shape.
Right.
Reflux, like sometimes I have a lot of patients that'll be like, oh, I thought it was reflux.
Right.
And they'll say, I'm having really bad reflux all the time, but I'm like drinking Pepto and taking Pepsid and taking...
And it doesn't help at all.
Right.
But it's got to still be reflux, although all the reflux stuff doesn't help it.
Right. So that's kind of where we're at, right? Atypical chest pain versus typical chest pain. So people who have typical chest pain that's related to the heart is usually exertional. If they hadn't seen a heart doctor, but their dad has nitro pills and they take the nitro pills and they feel better, exertional chest pain relieved by nitro, that's typical angina.
Yeah.
At its best. So they have a blockage.
And just to clarify, exertion can be physical exertion of I walked up that hill and then I really had to stop, and it might be chest pain, it might be a lot of shortness of breath, feeling nauseated with some chest discomfort, with any kind of exercise exertion. But we can also exert ourselves in emotional ways.
Sure.
And so you might get really stressed out about something that's making your heart beat faster, requiring more oxygen, and you start getting discomfort in that. And a lot of people will then start convincing themselves, well, it's anxiety. I was worked up, and then I got chest pain, and it was anxiety. But getting worked up can be a form of exertion on your body as well.
Sure.
So I think helping people understand, don't just write that off as anxiety, is also helpful, because it might actually even be typical chest pain.
Correct. So, a lot of times when people come in, if they have chest pain or shortness of breath or palpitations, we start off with the EKG. And sometimes the EKG will show some changes that are concerning, that you may need further workup, and that's when you guys call me, and then we'll get them set up for an echo and a stress test.
I'm like, please let Dr. Sims be at ESAD. Please let Dr. Sims be at ESAD today.
Right.
And when you say changes, I think it's important for people to know too, we only know if you have EKG changes if we know what your EKG once looked like.
Right.
And so we are really big here about getting EKGs on people and just having a baseline EKG, because many times,
especially for our hypertensives, I try to do that once a year. If you have high blood pressure,
if you have anything
or
that
diabetes,
might be, or you're on a cholesterol pill, anything, or you're a smoker,
Yeah.
anything that we go, you're probably at increased risk of having cardiac something down the road. We want to have a baseline.
And I'll tell
EKG.
patients, like, I need a baseline, because if you come in here with chest pain or something that's different, I have nothing to compare it
Right.
to.
Right.
So I feel like we try to do that.
Normal for you is not normal for everyone. We want to know what normal for you is on a good day when you aren't having issues.
Correct.
So having, I think, that EKG on file with your doctor is a good thing.
Yeah,
and so EKG changes, and then as soon as you see us and you have EKG changes, we are on speed dial going,
sure.
we're sending them to you.
Right. Yeah, and as much as we don't like electronic medical records, right, patients are savvy and they're in their portal, so they may have seen somebody else, or they say, you didn't know that they went over, to Walton or came to Eastside and Snellville or to Emory or to another, Northeast Georgia.
Yeah.
But lo and behold, they pull up on their portal and then they pull up their EKG, and so you see their old EKG and you can compare to the one you have and say, yeah, we have something going on. Let me send you to cardiology.
Yeah, so EKG changes, and EKG is it costs a piece of paper.
Right.
It's non-invasive. It's an easy preliminary test to do. So first we would say it's not up for patients to decide if you're having typical or atypical. Atypical chest pain is the less likely cardiac and more likely anxiety, GERD, other things.
Musculoskeletal.
Yeah. And musculoskeletal, one of the things we like to do is if I can push on that area and reproduce the pain, then that's a little bit
More
reassuring.
Sure.
But honestly, if you're at home and you're having something that you would possibly describe as chest pain, chest discomfort, I feel weird in my chest, see a doctor.
Mm-hmm.
This is one of the things where if it is cardiac, it can be a sudden cardiac death, and we might be able to get to it before when we're seeing these partial blockages and such.
Right.
So don't be at home convincing yourself that you know why you're having your chest pain.
I would rather be like, guess what? This is just musculoskeletal. This is not cardiac at all, as opposed to you being dead at home. Right?
Yes.
Like, come in.
Don't wait on it.
Yeah, don't wait on it. And so then, what about the person who's having chest pain at home? When do they see their primary care or an urgent care, and when should they go to the ER?
So if they're having unrelenting chest pain more than 15 minutes, they need to go straight to the ER. Do not pass go. Do not collect $200. Ideally, we want you to call 911, right? We don't want you to have the option, I'm going to go to the urgent care at Dr. Plaster, or I'm going to see her next week in clinic, and then you go to sleep and then you don't wake up.
Yes.
So if you're having chest pain that's unrelenting more than 15 minutes, then go to the ER to get checked out. That way we have all the services available to you. You don't have to come, over here, and then everybody's freaking out, and then send the EKG, call 911, and then, I say it's a STEMI, and it's like, oh, shoot.
Yes,
they
because
should have went straight to the ER.
You did not need to freak out your primary care doctor, and we very much appreciate it.
Like, I didn't want to call an ambulance, and I'm like, well, I'm calling the ambulance now because you did.
And then not only, to Dr. Sims' point, she should not be driving if you're having a heart attack, because we may have been able to fix the heart attack, but the fact that you're wrapped around a tree now,
or you killed somebody,
or you killed someone, and because you can't drive while you're having a heart attack. But also, when I was a resident doctor forever ago at University of Illinois at Chicago, we had in the ER, in the bathroom where all the staff went, was a sign that said time is muscle.
Right.
And time is muscle. So the longer that you are having a heart attack for, the more irreversible damage that you're going to have, or that you may end up in a sudden cardiac death situation.
Right.
And so get yourself to the place where they can go in and get blood flow back to your heart as soon as possible. Correct. Time to the cath lab is everything. Right. So while you're in our lobby, we had a patient who called, and our very smart people in our call center said, go to the ER. You're having this kind of chest pain for that period of time. It sounds very cardiac. You got to go to the ER. Well, you don't want to go to the ER because, let's face it, guys, no one wants to go to the ER. But you know what I want less than the ER? Death.
Right.
So you go to the ER because that's where you're going to get the best, fastest, conclusive, and a cardiologist and a cath lab as soon as possible.
Correct.
And I would say when you're having chest pain, don't just go to any ER. Go to an ER with a cath lab.
Correct.
And you should know this about your community hospitals.
For
which
sure.
ERs have cath labs and which don't.
Yeah.
And you can ask your primary cares, they'll tell you.
Yeah, most of your people out here know. So,
they do. Yep. And we'll tell them, and you can say it to the ambulance. Then go to the ER by ambulance, because when the ambulance gets to you, the clock is ticking and they're already taking action. They can give you some things to open your vessels up. They can get an aspirin on board, or morphine, or other things, so that we're starting the treatment to help with the blood flow. They're going to get you there safely. They're going to start getting EKGs and other things, and they're calling ahead to the hospital to say, hey, we see some EKG abnormalities here, and we think this guy's going to need the cath lab.
Right.
And the cardiologists are already getting down to the ER to receive you.
Correct.
Because now we got the ball in motion.
We're on the move.
You driving yourself there is not getting any ball in motion.
Right.
And then the faster we get you to the cath lab, the faster we're reperfusing that muscle, getting the blood flow back to your heart and preventing permanent damage.
Right.
And so time is muscle. Don't be wasting your time. The guy that we said get to the ER said, I don't want to go to the ER, and he came here. Yeah. So then our non-clinical staff there in the lobby are seeing this guy talking about his chest pain while he breaks into sweats. And they just get him straight back to the back, where our urgent care provider was like, you got to get to the ER right now. Just calling 911 to get an ambulance here. Oh, he's not going to take an ambulance. He's going to drive himself. Right. So then he pulls out. He knocks my fence over, pulling out. God bless him. I wasn't even mad at him because I was like, well, how good can you drive while you're having a heart attack? So I'm going to forgive you for that fence. Yeah. And then drives himself. And we still don't know what happened to the guy, but it seemed very much like he was having cardiac chest pain. Yeah. And all I could think is hours before this, we could have been fixing it.
Sure.
But instead, the stubbornness is actually going to create irreversible damage that could have been prevented.
Sure.
And so greater than 15 minutes chest pain and unrelenting, and you're not sure. And how many times do we say, I'd rather you be at the emergency room and find out you're okay than be at home and find out you're not, or be in my office and find out that you're not. So those kind of chest pains get to the ER.
And we have done cardiac compressions in the parking lot.
We have, and it wasn't my favorite day.
It was not my favorite day.
And it did. The person didn't make it because we can't do in our parking lot at primary care what you can do at the emergency room or in even an ambulance.
Right.
And so the chest pain in general, if you're having this intermittent chest pain comes and goes, you're not quite sure, see your primary care right away. And this isn't like, oh, I've got my hypertensive follow-up in 3 months, I'll talk about it then.
Right.
Let's make sure we're getting on top of this. And then the chest pain that gets to the emergency room, and it's not an absolute, okay, we have evidence. What's the workup of chest pain in the emergency room?
So they'll get an EKG. They'll get at least 2 sets of troponins, which is a marker. If it's elevated, suggests that you may, have a small heart attack or the beginnings of what they call acute coronary syndrome. So, normally ACS starts out as chest pain, then you have a small heart attack, and then you have the big heart attack. Well, if you can stop it at the chest pain and get a, stent put in before you have a small heart attack, which may or may not cause muscle damage, versus having a full-blown big heart attack, and then you're in your parking lot waiting hours, and anything, over 6 hours, probably irreversible, just like when people have stroke symptoms, and we know about that.
Yeah.
We got lucky with a scare out here when I first started out, and, we got an EKG. It was fine, right? And then it's like, where do you go? Where's the stroke center at?
Right.
They don't have it at Walton. They don't have it at Eastside. Do we go all the way down to Emory? I wasn't sure if Gwinnett Medical Center had it, but Athens did.
Yeah.
And so we got her there. Still had symptoms when we arrived, right?
Yeah.
I left an hour later, still having symptoms after they gave TPA. And then you called me, and she could move her arm and her leg again, which is a godsend.
Timing was everything.
Right.
Yeah.
Versus, and that's, so in the heart attack world, 15, 20 years ago, we would give TPA because we didn't have balloons and stents. Well, I say 15 years ago, 25 plus years ago, they would give TPA, hope the vessel would open back up. And
TPA is a clot reducer.
Yes. And
so when you have a blood clot that's blocking blood flow to your brain, we still use TPA to get the blood flow perfusion back to the brain.
Correct.
Stop the stroke.
Right.
Stop the permanent damage.
Right.
Used to do it for the clots in the heart, but now interventional cardiologist, Dr. Sims, and so many interventional cardiology, which means we have interventions.
Right.
We are trained to get you to the cath lab, where we're going to, when we say cath lab, what's a cath?
Heart cath, basically we go through the wrist now, and that started around 2007, 2008. Before that, we went through the groin.
And
So-
we know we're old because we remember all the, I'm like, yeah, and
Put
residency.
the
it's always
pressure.
different. Put the sandbag on.
on there. Yeah. You had to hold pressure for 20 minutes. And
Yeah.
they, you hope they don't get a hematoma or bleeding into the abdomen. But yeah, so now I would say, 85, 90% of the time, we all go through the wrist and go up. And a lot of, sometimes you have to have some patience because some people have a tortuous anatomy in their brachial area, subclavian. But if you
So
can,
you're feeding a camera-ish.
a tube and over a wire, and we're using X-ray camera, which is fluoroscopy.
We start with blood vessels in your wrist. We feed them through the blood vessels till we get to your heart. So
Yep.
we can actually look inside your blood vessels
Right.
and see where are narrowings, where are full blockages,
Correct.
what exactly is going on with these
Yeah.
blood vessels in your heart.
Yeah, so when we used to go through the groin, we would have to use 3 different catheters, and most of the time we can just use one catheter to look at both blood vessels. You have one on the left side, which has 2 vessels that come off of it. You have the left main, the LAD, or left anterior descending in the front, which people call the widowmaker, which to me, the left main is more of a widowmaker than, having blockage in the left anterior
And
descending.
widowmaker just means this is a big vessel. It supplies a lot of your heart.
Yeah, 50%
If it's
of your
not
heart
doing
muscle.
its job, your heart's probably not going to make it.
Yeah, you're in trouble. So the left anterior descending supplies 50% of your heart muscle, the circumflex in the back on the backside, 25, and the one on the right, 25%. So if you were to have a heart attack, yeah, you probably want to have it in your right coronary artery or the circ, or not have a heart attack at all.
Right.
But you definitely don't want to have it in the LAD, which supplies 50%.
And then while you're doing this cath, you'll either say, hey, cardiac cath was clean,
Right.
or you had some blockages.
Yep.
And at the time that you're seeing the blockages, you can go in and what
fix it,
comes
yeah.
after that.
Yeah, so if you have a blockage that's more than 70%, or if you have a blockage that basically has clot in it, then you need to put a wire, balloon, and then stent in there. There's spontaneous coronary artery dissection, which you normally see in women under stress, and those you shouldn't go in and wire and balloon the stent because they have worse outcomes. The other scenario that you see in women is called Takotsubo syndrome, where a woman has a stressful event, you get the EKG, it looks like a STEMI, and you get in there and you find out all the coronaries are normal, and then you take the catheter across the aortic valve into the ventricle, which is the squeeze of our heart muscle, and you do a power injection, and you see that globally from the tip of their heart to the mid part of their heart isn't moving, but the base at the bottom is moving. And so Takotsubo basically in Japanese is octopus pot. So they have these octopus pots they used to catch octopus with that it kind of looks like. And so the good thing about that is, yeah, it was a stressful situation that you had as a woman. If we put you on a beta blocker, in 30 days your heart function returns to normal, and then get you in to see your psychiatrist or your primary and get you on something.
Does it decrease ejection fraction?
Yeah.
Okay.
Yeah.
That's why the beta
Yeah.
blocker.
So it's usually less than 35%. Yep.
Okay.
Wow. Person has a normal stress test. How long can they go, I'm fine, I had a normal stress test?
Yeah. I normally do them every 2 years, depending on their risk factors.
Okay.
Which
Which means if it's been 7 years since your last normal stress test, stop acting like
that you're okay.
There's no
Yeah.
chance that
Yeah.
anything could be wrong.
Yeah,
'Cause
don't-
I'll have people say, "Oh, I had a normal stress test." Oh, that's reassuring. When was it? Oh, it was around 1995.
right. So I'm fine. Yeah.
Yes, I'm good. It's normal stress test. Normal cath. How long are we get out of jail free or feeling reassured after a normal cath?
I would probably say 5 years, but some people say 2.
Okay.
If you've
And again, risk factors.
if you've had bypass surgery, you can get away with not doing another stress test until basically 5 years after bypass surgery.
Perfect.
But everybody else, if you're high risk, high risk profile every 2 years. And when we were in training, they were doing stress tests, lighting people up
Yeah.
with nuclear imaging every year or every 6 months, which probably was abusing the system more than needed to be. So we use appropriate use criteria now in order to, get testing approved. And so I would say every 2 years if you're a high-risk patient.
So, Marcus, all your years of doing cardiology, what would be your takeaway messages on heart attacks and coronary artery disease?
try to find some exercise, some kind of way, reduce your risk profile, whether you're looking at your parents, history and what they had, because you might end up having it, even though you don't think you're going to get it. The best way to, not have it is to basically do things that would reduce that, i.e. change your diet and exercise, and then just know your numbers. Know your cholesterol, know what your hemoglobin A1C is, or at least know what your glucose is. And then when you hit certain markers, at 30, make sure you know what your cholesterol is, get an EKG. When you're 40, make sure you get a calcium score CT. If you get up into your 50s, I would say at least get a treadmill test. You don't necessarily have to have an echocardiogram done, because echoes get us in trouble when folks come in unless they really need it, because once you get an ultrasound and they have physiological regurgitation or trace regurgitation, now you're 50 and you got 3 kids and you want to get a life insurance policy and they won't cover anything cardiac.
Good point.
Because you went in for feeling fatigued or palpitations and you had physiological or trace regurgitation,
which is likely going to show up on so many echoes. Yeah, absolutely. Yeah. And Dr. Sims was kind enough to share his own story in our last episode, and I'm going to tag in with my own, which is very similar to yours. The more I ate oatmeal and tried to eat anything with a heart on the front of the box, the more my cholesterol stayed the same.
Right.
And so I certainly said, well, let me make lifestyle change because my cholesterol is elevated. Lifestyle change didn't budget much. I think the most that my cholesterol ever was an LDL of about 145. But if I were to practice what I preach, I want to get that down. And I was in my 30s when my LDL was in the 140. So that's, lots of years I'm hoping
building
for.
Up.
That I don't want it to build up. So I finally humbled myself and started a low dose of atorvastatin, which is generic Lipitor. And I'm not great at taking meds, and I probably take it 4 times a week, and my cholesterol is dropped in half. Yeah. And I was like, wow, that stuff that I give people really works. Yeah. And my takeaway really was the best heart attack is the one I never have.
Right.
And so let's do what we have to do to make sure that we are protecting. We have one heart. It is a common cause of injury and death. And so let's do what we have to do to protect it. And lifestyle change is necessary. And getting rid of those risk factors like smoking and having high cholesterol diets like eating marbleized steaks and all those kind of things, it is not without consequences.
Sure.
And so making those lifestyle changes necessary. If your numbers still aren't where you got to know your numbers to know if they're at goal. If they're not at goal, then let's make whatever necessary change we have to. And I have no clue that I take a statin. I have no muscle aches from it. I don't have any of the side effects. Those are the minority of people who end up not tolerating statins.
Sure.
And we're going to monitor you, and we have other options. But our advice from primary care and cardiology would be to protect your heart, to do what you have to do to protect your heart. After you've had an event, it is life altering. You may never go back to doing some of the things that you did before.
Correct.
You may, but you may not. So why take that chance?
Right. And if you do have side effects, I mean, you can go to every other day with a statin, and sometimes we just go to once a week. But at least you're helping to lower that LDL, so you don't end up having a plaque rupture that ends up causing you to have a heart attack.
Absolutely. Well, thank you so much, Marcus, for joining us to talk about chest pain and heart attacks. We appreciate you all listening in, and we'll see you back in 2 weeks.
We'd like to leave you on a good note, and here's today's Tell Me Something Good. Anniversaries. Really, wedding anniversaries are such a fabulous time to celebrate your relationship and to do great things. And really anniversaries of anything, being able to celebrate the time that we spend. Amber and I, fun fact, have a anniversary in common. She got married the same exact day that I did a few years after. So normally we remember to tell each other happy anniversary before we do our spouses. We probably see each other first at work before we see our spouses. So something good is anniversaries. Thank you for joining us today, and until next time, take care of yourself.